Okay, good afternoon, everyone. My name is Ariane Malexide. I am a third-year doctoral student in the Applied Social Psychology program at the George Washington University here in Washington, D.C. Today, I will be discussing a paper published in 2022 in the journal Current Opinions in HIV/AIDS that I co-authored, and the title of the article is Ending the HIV Epidemic for All, Not Just Some: Structural Racism as a Fundamental but Overlooked Social Structural Determinant in the U.S. HIV Epidemic. So I just want to thank the organizers of the DuPont Summit for inviting me to speak and anyone in the audience listening today. I don't plan to use the full 40 minutes to talk, so we'll definitely have some time for Q&A at the end, and we'll probably get out of here a little bit early. So I'd just first like to acknowledge my co-authors on this paper. My co-authors on this paper, Dr. Lisa Boleg is a professor in the psychology department at GW and the founding director of the Intersectionality Training Institute. She is the lead author on this paper and a leading scholar in the field of intersectionality and understanding social structural barriers to HIV prevention and treatment, particularly among ethnic minority populations in the United States. Rico Boone and Mary Mambaba and I are all doctoral students in Dr. Boleg's research lab at GW, and our lab's work primarily focuses on social and structural determinants research related to health equity, HIV, intersectionality, and mental and physical health outcomes for ethnic and sexual minorities in the US. So as I mentioned, I'm a current doctoral student at GW. I'm in the psychology department. And previously, I studied conflict resolution and global health policy at Georgetown University, where I received my master's degree. And in between my time at school, I worked for 6 years at the Fogarty International Center of the National Institutes of Health, or the NIH. And there I worked on several projects related to the global HIV epidemic. And when I started my PhD, I decided to pivot towards domestic health because there are just as many health issues to tackle here at home. So because this is not a health-focused conference, and I know there are folks in the audience probably from very different fields who might have different technical expertise, I thought I'd start with a little bit of background on the HIV epidemic in the United States to just get us all on the same page. And then I'll discuss how structural racism is a social structural determinant of the epidemic. I'll review recent scientific literature on the topic that we cover in the article. And then finally, I'll talk about what the literature says it will take to end the HIV epidemic in the United States. HIV is an infection, and it stands for the human immunodeficiency virus. If it is left untreated, it can become the acquired immune deficiency syndrome, also known as AIDS. And the first cases of HIV in the US were reported in 1981. HIV is spread through blood, semen, rectal and vaginal fluids, and breast milk. And because HIV weakens a person's immune system, it also reduces their capacity to fight other diseases. So more than 700,000 people in the US have died from HIV-related illnesses since the start of the epidemic. And today in the US, there are more than 1.2 million people living with HIV, and there are more than 35,000 new infections every year. So as you can see here from this chart, HIV-related deaths in the United States have declined significantly since their peak in 1995, during what was known as the AIDS epidemic. And this decline is primarily due to the availability of antiretroviral therapies, or ART, which is a series of medications that suppress the virus and its symptoms. And these have really been miracle drugs. They allow people to live long and full lives with HIV without it turning into AIDS, which is actually the deadly syndrome. HIV prevention involves 4 key activities: regular HIV testing, using condoms, and then PrEP, which is pre-exposure prophylaxis, which is a highly effective medication that prevents HIV. So for people who are HIV negative, who may have a partner who has HIV or is considered at high risk for acquiring the disease, They can take a daily oral pill, or now there's actually an injection that you can get every 2 months in the clinic, and it is 99% effective in preventing HIV transmission. And PrEP is widely available through government programs depending on the state you live in. In DC, for example, in many cases it's free for those considered at high risk for contracting HIV. And then also, of course, increasing people's awareness of their HIV risk and their prevention options is an important HIV prevention tool. So although HIV incidence has declined across the US and across the world, primarily due to the availability of ART medications to treat HIV and PrEP to prevent it, rates among Black and Hispanic people in the US is disproportionately high, or are disproportionately high. You can see here in 2019, Black people made up about 12% of the US population, but 40% of HIV cases. Similarly, Hispanic people were 19% of the population, but make up 25% of HIV cases. And then as a comparison, white people are 60% of the US population, but only 28% of HIV cases. And this is the same data, basically 1 year prior in 2018, showing HIV diagnoses by ethnicity relative to their population size. Just another way to show that there is a deep, deep inequity that exists across ethnic groups in terms of HIV incidence. The trends are similar for PrEP prescriptions, which is the medication that prevents HIV for those who are negative. In 2021, 78% of white people who were eligible for PrEP were prescribed it. 20% of eligible Hispanic people were prescribed PrEP in 2021, and only 11% of Black people who were eligible for PrEP were prescribed it. So not only do Black and Hispanic people in the US have higher rates of HIV, but they are also less likely to have access to the medication that would prevent it. The US government has committed millions of dollars to ending the HIV epidemic in the US by 2030. This is known as the EAG initiative. And as you can see here, these are federal funds that have either been proposed or allocated by year. But even with all of this funding, HIV prevalence rates are still stubbornly high among Black and brown populations in the US. And HIV prevention tools are just not reaching everyone equitably. So the question is then, what is preventing the end of the HIV epidemic in the US, and what accounts for these racial and ethnic health inequities? There is a growing consensus in the medical and scientific community that structural racism is a critical barrier to health equity, including related to HIV. Structural racism is defined as racism that is produced and reproduced by laws, rules, and practices, sanctioned and even implemented by various levels of government, and embedded in economic systems as well as in cultural and societal norms. The Centers for Disease Control and Prevention, the CDC, and the National Institutes of Health, the NIH, now acknowledge that structural racism is a determinant of health. Both organizations have recently committed research and funding to addressing structural racism in order to reduce health inequities across disease areas, including cancer, chronic diseases like obesity and diabetes, mental health, infectious diseases like HIV. And this is a shift. So although it's been long known among social and behavioral scientists that structural racism affects health, it's really just in the last few years that big research and funding organizations like the CDC and NIH have acknowledged it as a key barrier to advancing health equity in the United States. And the shift is really important because when we identify that the problem is at the structural or institutional level, then we can address it through policy change. In the words of Kim Blankenship, who was one of the first health scientists to highlight the importance of attending to structures in HIV research, when we focus on structures, we can locate the source of public health problems in factors in the social, economic, and political environments that shape and constrain individual and community and societal health outcomes. So unfortunately, most of the existing frameworks for social determinants of health and HIV do not include structural racism, and this is a big gap in the literature. So why should we focus on structures? First, most of the barriers to HIV prevention are in fact structural. And I'll talk about those in more detail when we review the literature, but we're targeting the problem where it's at. Second, focusing on structures provides opportunities to address and modify the root causes of HIV inequities, such as structural racism. Third, it yields a larger potential impact at the population level. So rather than just trying to adjust one individual's health behavior at a time, we can make societal shifts that impact millions of people at once. And fourth, it helps us avoid victim blaming and reinforcing the ideas that the inequities that we're seeing in HIV, for example, are intractable, because they are absolutely not. And finally, it rightly shifts the burden of responsibility from individuals to the systems that they live under. So to highlight what I mean when I'm talking about structural racism in the health context, each of these listed here are empirically documented barriers to HIV prevention and treatment. Incarceration, housing instability, police discrimination, neighborhood poverty, lack of health service utilization and access, community violence, lack of access to social services or transportation or healthcare. All of these are antecedents to structural racism. And this is a problem because the historical legacies of slavery and structural racism in the US explain why we are seeing inequities in health by racial and ethnic group. And these barriers here all disproportionately impact Black and Brown communities. COVID-19 was another stark example of how structural racism impacts the health of people of color. So although everyone was impacted by COVID, the virus disproportionately harmed Black and Brown communities because of the inequities that already existed in our systems, including healthcare, housing, social services, transportation, things like that. So our paper was published in Current Opinions in HIV/AIDS, and we analyzed articles published in peer-reviewed scientific journals between May 2020 and October 2021. And these articles highlight or advocate a need for greater attention to structural racism as a core determinant of HIV. In our paper, we also argue for the inclusion of structural racism in social determinants of health frameworks. We documented how barriers rooted in structural racism are associated with HIV incidence, risk, and prevention among particularly Black cisgender women and Black gay or bisexual men who are at the highest risk for HIV. And finally, we highlight future directions for centering the needs of racial and ethnic communities disproportionately affected by HIV, so as well as prioritizing community engagement and health research. So I'm going to briefly walk through some key points from these articles so they can get a sense of the landscape of the literature. So many of the editorial articles that we reviewed explicitly name ending structural racism as an essential step to ending the HIV epidemic in the United States. For example, Godley and colleagues highlighted how targeted structural reforms within the US criminal justice and healthcare systems could profoundly improve HIV outcomes for Black and other people of color, specifically looking at policing reforms, implementation of decarceration policies, elimination of the collateral consequences of incarceration, and access to high quality healthcare for all. Wharton and colleagues assert that dismantling social and structural inequities that result from racism and intersecting forms of discrimination must be prioritized if the US is to reach its goal to end the HIV epidemic by 2030. And Doshi and colleagues argue that the US HIV epidemic will not end without dismantling the effects of structural racism, and that researchers must prioritize structural interventions to end the HIV epidemic. A recurrent theme in several of the articles is that structural racism is the unifying link between the HIV and COVID-19 epidemics. To Blackstock, the structural racism is the nation's third pandemic. Along with COVID-19, structural racism will likely thwart the advances made towards ending the HIV epidemic. And Millay illustrated 9 structural racism pathways that contribute to both HIV and COVID-19, and argued that failure to target the social determinant of health in the national HIV response compounded COVID-19 spread. We also analyzed a set of empirical studies on this topic. One qualitative study by Blankenship and colleagues with low-income women in New Haven, Connecticut, showed how living in segregated neighborhoods was an HIV risk factor. So the study illustrated that housing vulnerabilities were tied to HIV transmission, and they argue that HIV reduction efforts require structural interventions that confront both systemic racial, gender, and class inequities. Another qualitative study by Randolph and colleagues with Black women living in low-income housing in the southern US found that structural racism, discrimination, and medical mistrust were key barriers to participants' utilization of health services, and in turn, HIV prevention services. In another study, data from a cohort study conducted in Atlanta, Georgia by Sullivan and colleagues suggests that structural racism and barriers to care, particularly lack of Medicaid expansion, explain HIV rates among Black men who have sex with men. And then finally, another cohort study by Kazanchi and colleagues showed that neighborhood deprivation and low income may help explain HIV rates among adults living with HIV in the Midwestern United States. Syndemic approaches generally are those that focus on the interaction between co-occurring individual level risk factors and broader social structural systems that shape them. So syndemics basically allows you to examine multiple factors or multiple health problems at once and then relate them to the larger structures that either create or reinforce them. And syndemic approaches give us important insights about how factors such as structural violence, for example, are implicated in the HIV epidemic. Another example of syndemics would be looking at HIV and COVID, which we saw before. So for example, one of the studies we reviewed from Nadezhir and colleagues is a qualitative study with Black women who are at HIV risk. And participants reported multiple social and structural barriers to PrEP uptake, which was the HIV prevention medication, including intimate partner violence, community violence, substance use, lack of access to social services, to transportation, and to childcare. Another study from Dyer and colleagues found that racism, incarceration, intimate partner violence, depression, and binge drinking were all co-occurring issues for Black, gay, bisexual men at high HIV risk. One literature review by Quinn and colleagues found that continuous exposure to traumatic violence could impact HIV outcomes among Black, gay, bisexual youth. And another literature by Mayer and colleagues found that structural and institutional factors such as societal and health system stigma and discrimination, punitive laws and criminalization, poverty, and violence and victimization are all key drivers of HIV risk among US men who have sex with men. So it's just a note, as although a lot of the recent literature underscores that syndemic approaches may be useful for reducing HIV or understanding HIV, particularly among gay and bisexual men, Sangaramuthi and Benton's article cautioned against prioritizing syndemic approaches, which emphasize the social and structural conditions of pathogens over intersectional approaches, which by contrast center interlocking the structural oppression of people as the core focus of analysis and intervention. Our paper also highlights that although the US has the End the HIV Epidemic Initiative and the White House has its own national HIV/AIDS strategy for the US, both of these plans fall short. They focus primarily on biomedical solutions. And in doing so, they ignore the fundamental root causes of racialized health inequities, which I just laid out. And they've traditionally failed to engage equitably and ethically with communities most disproportionately affected by HIV. So going forward, how do we address the HIV epidemic? Community engagement is essential. Across the scientific literature, community engagement is highlighted as the most promising and important route for ending the epidemic, specifically for people of color in the United States. And that's because communities benefit most from interventions that are born from community advocacy and from community-based organizations. And one of the reasons for this is that these programs prioritize attention to inequitable social structural realities that allow HIV to spread in those communities. Some notable examples of effective community-based collaborations are listed here. They include the integration of services provided by community-based pharmacists with those of medical providers to improve retention and care and adherence to HIV medications. Using community-engaged development of mobile HIV prevention apps for Black women. One study demonstrated clinic-based strategies to improve care outcomes among people living with HIV who were experiencing homelessness or who had unstable housing. And finally, concept mapping of multi-level resilience resources among Black people living with HIV in the Southern United States. So these are some examples from the literature of community engagement approaches. And of course, if it was not clear from the presentation, the path to ending the HIV epidemic is by prioritizing structure. We should be focusing on health as a property of structure rather than just focusing on individuals and their behaviors. Importantly, although this was not the focus of our paper, attending to intersectionality is also crucial. So looking at the intersections of structural racism, sexism, classism, heterosexism, cisgenderism, ableism, nativism, all the isms will actually help us make progress in this space. So I will stop there. I'll open up the floor for some Q&A. And if anyone wants to reach out to me offline, this is my email address. Thank you.
Thank you very much. It's very interesting. Now we invite the people in the public to ask any question, either in the room or remotely.
Yeah, there is no question in the room. Does anyone have question on Zoom?
Maybe give them a second.
Okay, well, I do have a question. Maybe I ask first.
Right.
When we talk about the structural racism, did you take account into some influential factors like culture or language?
Can you say that one more time?
Because we compare the rate of different race in the US and different rate of HIV. So when we do this survey, do we consider the cultural influence and language?
Yeah, so when we're thinking about structural racism, certainly culture influences how people interact with their health, right? Their health behaviors, their health choices. So yes, absolutely. And language is of course a huge barrier for health literacy. So when we're thinking about creating structures or institutions that are not racist and building, you should absolutely be taking culture and language into consideration.
Oh, cool. Thank you. Okay, I think that's it. There is no more question. If anybody have more question, you can contact Ariana by her email.
Thank you so much.
Thank you. Have a great day.
Thank you. You too.